A very good afternoon. Well, welcome to the Zeiss Retina Symposium, Seeing More Than Ever Before. We will be having very interesting talks on imaging, the newer modalities of imaging. First of all, I would like to invite Dr. Shobhit Chawla, he's already there, and the speakers, Dr. Sangeet Mittal, Dr. Darius Shroff, Dr. Atul Ursekar. Can we have them in the dais? Yeah. Please, sir. So before we start, a small introduction. Well, I'm Dr. Anirudh. I'm the moderator for this session. I'm a practicing VR surgeon in Kolkata for the last 16 years. Dr. Shobhit Chawla doesn't need any introduction. Well, as a customary small introduction for him, he is a pioneer in modern vitreoretinal surgeries in North India as well as India, and is the medical director and the chief vitreoretinal services at Prakash Netra Kendra, Lucknow, a leading center for the advanced eye surgeries. He is the co-founder and ex-president of VRSI and has been instrumental in establishing the society in ASRS, Uretina, and the Egyptian Vitreoretinal Society, represented AIOS at American Academy and World Ophthalmology Congress. Visiting fellow to Singapore National Eye Center, Craig Eye Institute, Detroit, Oregon Eye Center, Eugene. Won various anatomic national and international awards, including the Honor Award at the ASRS. Authored and presented various papers in national and international congresses. I would like to invite Dr. Shobhit Chawla for his keynote talk on the emerging role of Octa and the ultra-wide field imaging in retinal diagnosis and management. Sir.
Thank you very much, Anirudh. So a good imaging system is what helps me see more, make a diagnosis, follow up my patients, make a treatment strategy, and monitor that medical or surgical treatment. And that is what ultra-wide field imaging and Octa have provided. So when we compare the various views, we have the slit lamp view, the direct ophthalmoscope view, the indirect ophthalmoscope, the traditional fundus view, and the Claris wide field, and the ultra-wide field imaging views, which are commonly used, and also the Optos. So there has been good evolution of fundus imaging right from 1926, when the first modern fundus camera was there, to 1992 when ICG came, and now finally in 2018 when ultra-wide field true color imaging emerged, while we still had imaging from Optos earlier and by the Heidelberg system earlier. So these are some of the options with us, and which give us various fields of views ranging from 200 to 105 in the wide field, 133 Strangui lens going up till 150 in the red cam. Now it was very relevant in the last 2 years, even for simple patient screening in the outpatient, when we were too afraid to come in close proximity to patients, we could just screen using a nice wide field color image and then do indirect ophthalmoscopy or more imaging as needed. So these, in diabetic eyes, we could avoid angiography and just do an en-face surface Octa and get an idea of the perfusion. Small pupil, a patient hypertensive for 5 years, poor dilator. In screening, we see, and the pupil was very small to allow good indirect. We see a hemi retinal vein occlusion on the first visit and then got treated with laser photocoagulation after a wide field fluorescent angiography. Another image of idiopathic vasculitis, lasered before, came for follow-up, and we could see on imaging some red dots superiorly, and did an angiography, and there was an NV sitting in the other quadrant. So this is all the relevance of wide field imaging. And when you go in depth and combine it with a wide octa, you see these new blood vessels. And these suspicious areas, you can again do a montage, and you can do various cuts like the NFAS image, the surface image, and the NFAS VR interface, where you see these vessels are visible and are little elevated from the retinal surface, as you see on the image in the right. So all the information you are getting without doing a dye injection. Then you take a cut through that, and you see the NV, new blood vessels, sitting at the vitreoretinal, and a localized vitreous small detachment going on the posterior hyaloid with the potential to bleed and cause sight-threatening complications. Another montage with all the imaging of the same case, where you have the fluorescein, so you combine all the modalities and get a better understanding of the disease, and then do your treatment. In diabetic retinopathy, it's a great tool to monitor progression, and many patients have predominantly peripheral diabetic retinopathy. It's very important for pre-surgical planning and plane of dissection, as I'll show you. So this is a very relevant study utilizing two types of fundus cameras, one the Optos and one the Clarus. And in Asian and Indian eyes, most of the lesions were found in zone C1, which is the posterior probe, 38.5 in the zone C2, which is the mid-peripheral zone, and peripheral lesions were relatively less. So primarily South Asian population tends to present with primarily center-involving lesions more in diabetic retinopathy. This was the study in investigative ophthalmology and visual science in 2018. And similar results were seen in an Indian study, very well done, and it monitored all these lesions and found that sight-threatening lesions such as NVE and NVD were detected equally by both Optos and Clarus in C1, whereas other lesions like cotton wool spots, hard exudates, and subhyaloid were identified better by the Zeiss Clarus in zone C1. So maybe pertaining to our context, the central imaging has more value than peripheral imaging alone. So you have a patient who you are following up after panretinal photocoagulation. You see some areas of missed panretinal photocoagulation, and you can do an imaging and fill up that area. A case of proliferative retinopathy with tractional RD, excellent image for planning your treatment, and I would go in for bimanual dissection in such a case. Another case showing neovascularization in the periphery also, along with the central tractional RD with a membrane. In retinal degenerations, you are seeing the fundus, but when you do a pan image, you see the periphery also, and you see the lesions all over. Good for monitoring lattice degenerations and deciding whether you need to coagulate or not, depending upon the presence of hole and the state of the vitreous. In rhegmatogenous RD, we routinely image now to see and decide whether we would like to go ahead with a buccal or a vitrectomy in a particular case, and make our decision according to the configuration, size, and location of the breaks. Another patient with a meiotic pupil came to the OPD, and we were screening him, and we saw this subclinical RD. He underwent a photocoagulation. He was a 68-year-old physician and was complaining of flashes and floaters, and the pupil was pretty small. A buccal surgery which showed fluid in an 8-year-old boy, and we saw this break which was posterior to the buccal, and the cause of the failure very easily detected by wide field imaging. And you can toggle the magnification to the area of interest where you suspect and see this, and then take the action whether you want to shift the buccal posteriorly or you want to go ahead and do a vitrectomy and laser. In vascular occlusion like central retinal veil occlusion, a fresh case, you see the extent of the disease, and it's almost bordering on to hemorrhagic. You would like to follow up this patient closely and monitor for peripheral ischemia with a follow-up angiography. In an old, dried out CRVO, you see this area with peripheral neovascularizations, collateral at the disc. You take a wide field image and then toggle onto the areas of interest with magnification, and you see so much information. Another case of retinal vascular occlusion. Vasculitis, another patient showing NVE in one area along with hemorrhage, and you can accordingly treat that area. The other eye also shows evidences of vasculitis. Vasculitis with serpiginous and high suspicion of Cox in this patient. Patient had vitritis also to some extent. And we subjected him to other investigations like HRCT for the chest, Manto, and quantiferon gold, which all have come positive, and he's already on ATT. Choroiditis to monitor and see the lesions where areas are active in the periphery. And another case of proliferative retinopathy, to see by a wide field OCT scan whether there is traction at the macula to take definitive action or not, or follow up the patient. Here the macula is threatened, so I feel surgery, this patient would be a candidate once the vision starts slipping. Now this is again in a small pupil discovered this peripheral hemorrhagic PCV lesion type lesion in a elderly lady, and you do an ICG wide field and you see those polyps there. This patient definitely requires treatment. Her other eye, again with polyps sitting in the periphery but no leak, this can be watched. So these are the advantages. Central peripheral PCV along with peripheral lesions, again polyps, and this patient also requires treatment, as you can see. A patient who has undergone, only-eyed patient who's undergone more than 30 injections, has been on aflibercept monotherapy, maintains six vision in his only eye, a practicing lawyer, and you see the branching vascular networks. You first do a whole image. Those are some areas which I have lasered also with polyps based on ICG, and when you look at the central magnified image, you see the branching vascular networks which have matured, and such networks have lesser chances of bleed. So imaging combines so much information, so much follow-up care, and so much treatment. You see the same patient showing similar lesions, and you can see on a wide field Octa image the branching vascular networks almost looking like a bush, but the vessels are mature, and these patients tend not to bleed later once the branching vascular network matures. A patient with a bullous RD almost touching the lens with PVR underwent, I did surgery for him, and my fellows noticed next day there were some bubbles underneath the retina, and we did a wide field image and then saw this area of interest, and A corresponding OCT shows PFCL under oil. Recurrent submacular hemorrhage, follow-up image with TPA and anti-VGF. Subsequently, Octa can be done to evaluate further management and a wide field ICG. Thank you very much for your kind attention. Thank you.
Thank you, sir, for the excellent presentation. Well, we will have the panel discussion after the talks. We have a similar topic, but with a newer modality, like we have the ultra-wide field imaging, but with oral fluorescent angiogram. This talk will be given by Dr. Sangeet Mittal. Can I have the slides?
This one?
Yeah, let me introduce Dr. Sangeet Mittal. He is the director, Vitreoretina Thin Eye Hospital, Jalandhar, Punjab. He did his fellowship in Wear Surgery and was awarded the V.T. Joshi Gold Medal for the Best Fellow. Did MS Ophthalmology from PGH Chandigarh in 1995. Best of the Show Award at EVRS for 3 consecutive years, 2017, 18, and 19, all innovative videos, 3 awards at AIOS and CS Rashmi Award Video, ET Selvan, the Best Poster Award, and the AIOS Trauma Award at recently concluded AIOS 2021. He also won the JM Power Best Paper Award at VRSI 2009. I would request Dr. Mittal to give his talk on oral fluorescent angiography.
Mike, yeah. Thank you, Dr. Anirudh, for the kind introduction. So good afternoon, everyone. My talk for today is minimally invasive oral FFA using broadline imaging technology. Fluorescent angiography, as we all know, has been in vogue since 1961. And it uses the injection of fluorescent dye to study the vascularity of the retina, and different lesions are diagnosed on the basis of the hypo or hyperfluorescence of the lesion. But even today, after more than 25 years of my practice in vitreoretinal, the only one thing that I am still jittery of doing is the fundus fluorescein angiography. Not because of the procedure itself is difficult, but because of the complications that are associated with FFA. And the fear of injection that exists in the mind of the patient, it's very difficult to convince him to undergo FFA. FFA, lots and lots of problems, allergy to the dye, nausea or vomiting, urticaria, anaphylaxis in some patients also, and even rarely 1 in 22,000 patients have lost their life also after FFA. Again, a vasovagal syncope just because of the fear of the injection, and again, it is limited use in bronchial asthma, nephropathy, and pregnancy. Ultimately, FFA becomes an invasive, not easily repeatable investigation, and the fear of injection exists not only in the mind of the patient, but also of the technician or the doctor who is doing the FFA. So oral FFA is not a new procedure. It was first use of oral fluorescent angiography was reported in 1979 using the analog fundus camera, but the image quality was not very good. Then Hara et al. In 98 reported using oral fluorescent angiography using a digital fundus camera. Image quality was better, but still not acceptable in certain diseases. Then SLO was also used to do oral fluorescent angiography. Again, the good quality images with CSLO were seen as compared to film-based fundus camera. And Dr. Rajvardhan Azad et al. In 2006 reported using OFA using CSLO. They also said good quality images with CSLO as compared to digital fundus camera. But another problem of using oral angiography was the availability of the oral tablets of fluorescein that were being used to do this fluorescein angiography procedure. So broadline fundus imaging by Zeiss in Zeiss Claris, what is it? It uses a broad rectangle of light which is scanned across the retina and detected using a monochromatic camera. So true color images are generated through sequential illumination by broad spectrum red, green and blue LEDs. And this gives a true natural looking fundus as it appears through direct observation. And by using a slit to only illuminate a portion of retina at a time, broadline fundus imaging limits the amount of unwanted scattering and reflections from the eye, thus enabling imaging a wider field than classic fundus cameras, which eliminates the whole field simultaneously. So the difference between the CSLO and broadline imaging is that it gives you a true color images as compared to the CSLO based images. And the normal fundus camera, the whole of the fundus is illuminated simultaneously, but in broadline fundus imaging, it is a sequential imaging, and then all the images are stitched together to form a form an ultimate photograph. So we have used this oral fluorescein angiography using broadline imaging ultra wide field camera. And we use 445 eyes of, this is a slightly older data, about 2 years old. 236 patients underwent fluorescein angiography, and the dye was given in the dose of 25 milligrams per kilogram body weight. So what we used were, we used the same ampules which we use for intravenous angiography. We used the same ampules. The dye was dissolved in 30 ml sugar-free juice, which was followed by another 30 ml of juice without the dye, just to change the taste, which is bitter, a little bit bitter. The dye is a little bit bitter. And then the angiograms were taken at regular intervals every minute for first 5 minutes, followed by every 2 minutes for 5 to 10 minutes, followed by every 5 minutes up to 30 minutes. And we obtained good quality images in almost 95.3% of patients and average quality images in 3.8% of patients. So almost 99% of the times we got good quality images, average to good quality images, which gave us the diagnosis quite comfortably. And the earliest images we were obtained were ranging from 1 minute 30 seconds to 26 minutes 25 seconds, but mostly it was in the range of 8 to 9 minutes that we used to get the first image after giving the oral fluorescein dye. And we compared it with our previous patients who had undergone IVFFA. The complication rate was quite less. The nausea and vomiting was less than 1%, which was as high as about 6% in the IVFFA. So most of the unpleasantness that is being seen in your clinics while doing FFA just goes away. Hardly any patients we see of nausea and vomiting after giving the oral fluorescein angiography, after doing the oral fluorescein angiography as compared to IV. There was a mild rash in 1.27% patients. And the difference in the IVFFA and the oral FFA in this allergy component was that in IVFFA you used to get the rash immediately within 20 minutes, but in oral FFA the rash is slowly, it develops after 20 minutes, and so you just have to keep a patient a little bit longer in your clinic to follow up whether he's developing any allergy or not. Severe allergy, in none of these patients, whereas in 3 patients we had a severe allergy in the IV FFA group, and the vasovagal syncope, none, because there was no injection involved, but in IV FFA it was quite high, 1.19% was significantly different. So comparing oral FFA with IV FFA, oral FFA is safer, it's less invasive and comfortable, the preparation is faster and can be performed by technician itself. It can be easily repeated. Patients do agree to get even after a month, if I ask my patient to get a FFA done, he is he goes ahead with it. Then in pediatric patients, the children are very easily, you can convince that you can, because they are very afraid of those injections. In patients who are contraindicated to IV injections, you can do an oral FFA, and you can even do multiple procedures simultaneously because the dye takes time to wash off. So you can do 2-3 patients simultaneously, just keep them altering one by one on the fundus camera. But IVFFA still is a standard, and you get a better arterial and choroidal phase only on the IVFFA, and definitely it takes lesser time. You just finish up the procedure in 5 minutes time. But as I told you, because of the oral FFA, you can do multiple patients also together. So the time comes out to be the same. So some patients in pediatric, it's easier than IVFFA because it's well tolerated and children do resist IV injections. So these are some of these patients you see. This is the oral FFA which is done in a patient of Coats disease, a 7-year-old girl who had Coats disease, and you see a good quality images present. There was a cystoid macular edema. You can make out the peripheral aneurysms, and you can make out the peripheral leakages, exudates on this. So this is a patient of FPVR. You can see that typical torchlight bulbs in the periphery and on this. So this can be easily used in children. So this is a patient of branch retinal artery occlusion. Though I told you that arterial and choroidal phase you can't capture with the oral angiography, but you can still make out that on an oral FFA that some of the cattle tracts that are present in the arteries. So these days, in the presence of OCTA, when you say where does this oral FFA will stand against the OCTA? So oral FFA is minimally invasive, whereas the OCTA is totally non-invasive. But the oral FFA is a dynamic procedure, and OCTA is a static procedure. So the lesions in which there is no blood flow, you miss while you do OCTA, like microaneurysms or the macroaneurysms. But in dynamic, for the oral FFA, it's dynamic. You can see the leakages in CSR. You can see the leaking microaneurysms very clearly, and subtle lesions can be picked up easily, which again can be missed with OCTA. True extent of disease can be picked up with the oral FFA, and these cameras are wide field cameras, so you can do it even up to the periphery. And it's again easier in patients with poor fixation. The people who have got the OCTA know the patient who has got a poorer vision, it's very difficult to get a good quality OCTA image in those patients. But OCTA still I feel is better for the CNVM, is faster, and again better follow-up you can do with the OCTA. So this is a patient of in which dynamic angiography I'll show you. You see this patient, the dye came in 9 point. You can see the hotspot forming, and you can see the leakage, the smokestack appearance, leakage in a CSR. Then again, this is an ink blot leakage in a patient of CSR. You can see the dye coming into the hotspot starting to appear at 9 minutes. And it increases in the intensity and size later on. And this was another patient of CSR. You can make out the hotspot and the leakage of the dye. So in uveitis cases also, you sometimes need a dynamic angiography. In this patient of serpiginous choroiditis, you can see there's an early hypofluorescence followed by a late hyperfluorescence. So you can't get these pictures on OCTA. This is a patient of APM PPE post-COVID vaccination, and again you see on OCTA you can't pick up these lesions, but on oral FFA you can see that there's an early hypofluorescence of the lesions which later leak on and get hyperfluorescent. Then for exudative AMD or classic CNV, I still say that OCTA is a better investigation tool, but though you can still make out on oral FFA also, you can see a leaking CNVM present inferior to the fovea in these patients. Then for retinal macroaneurysms, again you can pick them up on oral FFA other than on OCTA. For very subtle lesions like these subtle new vessels, you see the fundus picture, you can hardly see any new vessels in these, but you see a lot of NVEs present in there. Then for subtle NVDs, again, you see OCTA won't give you a true extent of the picture, but oral FFA, you picked up a lot more than this. So this was a patient of diabetic retinopathy. You can see capillary non-perfusion in the periphery, which can be easily missed on OCTA. So this was a patient who had a bilateral CRVO, and you did an oral. You can see the patient was of Takayasu's arthritis, classic peripheral non-perfusion in Takayasu's arthritis. So you can pick up these patients. Then Dr. Shobit has already highlighted the use of the wide field angiography. And you can even do this oral FA with the normal digital fundus camera, and you can still get very good quality images. For diabetic retinopathy, I'll just rush through these slides. For diffuse macular edema, you can pick up the leaking capillary blood, you can pick up the ischemic macula, you can pick up capillary non-perfusion. So diabetes is one of the most common disease for where you have to do an angiography. So you can pick up very subtle NVDs, even in patients of steroid hyalosis where OCTA does not have any role, you can pick up good lesions after beyond that. Then again, the limitations of this oral FFA, very heavy patients, you won't get very good quality pictures. In like more than 100 kgs patients, then patients who had a history of recent meal, within 1 hour you don't get good pictures, and patients with significant cataract, you don't get good pictures. So to conclude, oral FA is a safe, less invasive, well-tolerated procedure with high sensitivity. Quality images can be obtained in about 99% patients and can be performed in most indications. And to obtain a comprehensive evaluation in common retinal diseases and to reduce risks and discomforts of the IVFA, oral FFA may be considered for clinical purposes. Thanks a lot. Thank you.
Thank you, Dr. Mittal, for an excellent presentation. Well, I have a few questions. Like, what is the time we need to wait till we get a good picture in this oral fluorescent angiogram?
So if we see the range is from 1 minute 30 seconds to 26 minutes. In the study that we had done, but most of the patients who had their first images was about 8 minutes to 9 minutes. 8 to 9 minutes.
So we need to make the patient sit and check out whether the images are coming.
You can decide on clinical basis in which patients you need a very early image, or in which patients even the AV phase is okay for you. Like in diabetic retinopathy, sometimes even the AV phase is okay. You don't need the arterial and the choroidal or the very early images. In those cases, you can ask the patient, you wait, I'll take an image after 8 minutes, get the good picture at that time. Or you can, what we generally follow nowadays is we start every 2 minutes, we take for the first 10 minutes, and then every 10 minutes after that.
Sangeet, do you alter the dose in a early nephropathy patient with mild to moderate nephropathy, or oral dose is fine?
We have kept it the same, sir. I asked my nephrologist, and he said there will be no problems.
Yeah. Because many times they advise us to do a half dose when we are doing IV.
Yes, sir, but the clearing definitely takes a longer time because large amount of dye is given to the patient. So the patient stains yellow after this for about 6 to 7 hours.
Any case of anaphylactic shock, which?
No patient. No severe allergies, no shock, no vasovagal. No.
So the side effects are much less.
Yes, much less.
Much less. The only drawback is, I think, the time.
Time is the main. But then you can club your patients. You can have your 3-4 patients sitting together, and you start the FFAs and just keep them altering one by one to the fundus camera.
And I think you mentioned in your presentation the filling delay cannot be evaluated with this oral angiogram.
Yes.
So that's the two drawbacks.
That's a true drawback.
And regarding you have immense experience in this oral fluorescent angiogram. So do you feel the image quality is almost the same as an IV angiogram, the conventional one?
Yeah. Yes. Yeah, you can use them. IV with as compared to IV, yeah, it's same. No problems. I asked my nephrologist when we started this thing, and he said you can use it freely, no problems. You are giving, but the absorption is, I think, still lesser as compared to the IV. The amount of dye that is going into the bloodstream almost the same.
Could you please tell us about the instrumentation? Could you please highlight on the instrument exactly what are you using? The regional fundus camera, or what kind of camera are you using to capture this?
So I've used both. I had used the digital fundus camera by the Carl Zeiss team, And now I'm using the Zeiss Claris, that is the broadline imaging technology by the Zeiss again. So you can use it on digital fundus camera. I showed some pictures of the digital fundus camera also.
And where do we get this fluorescent tablets? Like, is it easily available?
No, these is not tablets. So these are the same ampules.
Okay.
These are the same ampules that you use for the IV. In a 25 milligram per kilogram body weight, you mix it with the orange juice and give it to the patient for injection.
Okay. Okay. And do we have any tablets? That's what we were mentioning in our presentation.
We had tablets,
Okay.
yeah, but it's not easily available.
So, any questions on the wide field angiogram?
I just want to ask you one question.
Yes, sir.
Have you used ICG also in the
Claris?
Claris system?
Not yet, sir.
And okay.
I think there's a technical difficulty in incorporating ICG into Claris because they are using light as the scanning system. But they are coming up with a short modification. I think within this year only they will.
Yeah, because that's just what I was wondering.
Yeah.
Because I still use the Heidelberg system for all my
Yes.
ICG and it's SLO based.
So oral FFA works very well with the Heidelberg also and with the the Optus also. I have used that also.
Okay.
Thank you, Dr. Mittal. It was a great talk. Well, we move on to the next talk by Dr. Atul Ursekar. The topic is practical features and the clinical applications of Octa. Let me introduce Dr. Atul, qualified from JS Medical College and KM Hospital for undergraduate and postgraduate specialization, Retina Fellowship from Shankar Nethalaya. Did his Retina Fellowship with Dr. Yanuzzi at Manhattan Eye, Ear and Throat Hospital. Private practice at Ursekar Eye Clinic, Mumbai. Consultant at Yashlok Hospital and the Reliance Foundation Hospital. Teacher and guide to many postgraduate students. And I experienced in using and a keen interest in multimodal imaging. Dr. Atul, please.
Is there a pointer or just use the mouse? Pointer के लिए?
Just send me 2 of your slides on the working of Zeiss system, the broadline one and the other one with the 3 red, green and
Next slide के लिए किधर जाना है? Page down. So good morning everybody, and I'm going to be speaking on OCT angiography. Some practical points, both the combination of technology, the advantages, some shortcomings, and where this new method of imaging helps us. So before we begin, I'm sure everybody is not fully conversant with the technology, so a few important points to keep in mind is that OCT angiography means the machine takes repeated B scans in the same location, and what it identifies is motion. And the only thing that moves in the retina is the retinal blood cells, and that's how you get the angiography image. That's 99% of the time. 1% of the time is some exceptions, which I'll show you. And what this means is that a static image, as you see on the left side, is then converted into a dynamic image of retinal blood cell flow. And this uses various mathematical algorithms. They have all sorts of complex names, but effectively you get an image something like this. And there are some special caveats which you have to understand, is that when measuring the flow of blood cells, if the flow is too fast, as in the choroid, or if it is too slow, for example in polyps, then it may not show any flow. So this is an important thing to keep in mind. Also, it's very important that the image must be static in the sense that at the point of capture, because if there is too much movement, you are not going to be able to capture a good image. So there are special tracking technologies which are in the machine, and I'll show you some examples of how effectively that works. So another important thing about OCT angiography is the software. And what the software does is that it segments the various layers. And this is critical in identifying the disease because effectively what differentiates OCT angiography from all other angiographies is that this is a three-dimensional imaging. And this is where it stands out as compared to the other methods of angiography. So segmentation can be so important, as you can see here, where the two lines which are segmenting are in the wrong location and the lesion is not seen. Whereas if the segmentation is done properly, you can see the two lines being well properly placed. So as to say, like calipers, the lesion is well identified. And this is very, very important both to learn to do and in the interpretation of OCT angiography. Obviously, being a digital method, another advantage is that it gives you quantitative analysis. I'm not going to go into the intricate details, but basically what it gives you is the potential for perfusion in that area, and this is measured either in the form of vessel density or in the form of perfusion density. And again, I'll show you some examples of how that can be useful. So this is vessel density. But what is very, very important is the quality of the image. As you can see in this chart, if the quality of the image is good, then there's very little what is known as coefficient of variation. So the images won't be different. Whereas if the quality of the image is bad, you are going to get a very poorly interpretable image. So this is very important. You just cannot do a slipshod job of imaging. So let us look at clinical applications. So this is a patient who was diabetic, who had CSME. As you can see on the left-hand side, she has severe edema. And after anti-VEGF treatment, the edema has resolved. And she was reluctant to undergo fluorescein angiography. She also had high BUN creatinine. I think we've discussed that, but there's still some hesitation in doing this. And also, of course, sometimes you have patients who have known allergies to fluorescein. So I did her OCT angiography, and you can see in the center of the retina seems to be well perfused in both eyes, the right and the left. But when moving to the periphery, you can see that there are large areas of non-perfusion. And in fact, in the other eye, one can see that there is early intraretinal neovascularization. So from a patient who would otherwise walk out of your clinic, you're suddenly now considering altering the method of treatment. So this is the importance where OCT angiography helps you to perform tests which you would otherwise possibly not do. For example, even in diabetic patients, a pregnant patient who is diabetic, you may not, or you may hesitate to do angiograms, whereas here you can do it very easily. Also, it has been said that you will not see microaneurysms, and here's a patient with diabetic CSME, and you can see microaneurysms, which are even visible if you take a good quality OCT angiography. What is important here is you can see the full extent of the foveolar vascular zone, and this is where OCT angiography beats any other form of angiography. So this is a very practically important thing to keep in mind. Here's a patient where you can see a fluorescent angiography has been done, and below is the OCT angiography of the same eye. And you can see that this area is obscured because of leakage. The detail of non-perfusion as well as the foveolar vascular zone is far better defined in OCT angiography. So this is a point of practical importance. This is a patient with diabetic CSME with a lot of circinate hard exudates. This is before treatment and after treatment. OCT angiography allows you to see a particular sign which is not available in any form of angiography, and that is called SSPM, that is scattered suspended particles in motion. Now this is a patient in which you can see the edema is quite severe, and this is the superficial layer. You can see the cystoid spaces, but you can see granular material. Now it may not be so well evident in the superficial layer, but if you look at the deeper layer, you can see this particular scattered granular material, which is called SSPM. It's supposed to be possibly due to proteinaceous material or lipid material, and this is not visible in a conventional angiography. Now, what is the importance of that? Particularly in patients who have this sort of heavy lipid leakage, you can see before and after treatment, the edema has reduced, but the SSPM has also significantly reduced. This is in the superficial layer, and you can see the improvement. All this granular material has gone. It is not granular material, it is some kind of exudate which is throwing shadows because of motion. So this is a situation where that 1%, where not RBCs, but some other material is showing a shadow. And this patient then, of course, has complete resolution of the edema. So this is something which is unique to OCT angiography. Also, this is a patient who was diabetic, non-compliant. You can see chronic edema, a lot of cystoid spaces. But by using the quantitative analysis, I could show the patient that both the vessel density, you see the vessel density, the number of red areas which are gradually reducing and the blue areas which are increasing, as well as the perfusion density, where you can see the blue areas are gradually increasing. So you can see the edema may appear to be the same on conventional OCT, but the perfusion as well as vessel density shows how the patient is deteriorating, and you can sort of discuss this with the patient to improve compliance. In branched retinal vein occlusion, just another example, this is the type of image that you would get probably with an FFA, and this shows you the superficial vascular network. But as I told you, OCT angiography shows you a three-dimensional network, and you can see the severity to which the deeper or the middle vascular layer is affected as compared to the superficial layer. So this, in fact, gives you an indication of the severity of damage to the retina which has occurred. Now, here's an example of central vein occlusion, classic hemorrhages and edema. And you can see here, this was before treatment, and this is after anti-VEGF treatment. But you can see that the vessel density has not improved significantly as compared to the baseline picture. And this was 3 months apart, but subsequently 6 months later, despite the fact that there's no edema, the vessel density has improved. So vessel density is another indication of how the vascular flow is improving, which goes beyond just the fact that you're looking at edema being present or absent. And then, of course, we've seen pictures of MacTel where you know the clinical signs on conventional fundus photography, and you are also aware that everything gets completely obscured with fluorescent angiography. So essentially, it's just a diagnosis where you're not seeing the disease, but you're identifying it by the fact that there's leakage. Is that timing or? Oh, 1 minute, sorry.
Sir, you continue. We have enough time.
Okay, fine. So the advantages of OCT angiography is, you can see in this this is where there is no segmentation. This includes all the layers, but the segmentation is done in a color-coded manner, and you can see from the superficial to the deep layer the complete anastomosis of the MacTel. Of course, OCT angiography shines in choroidal vascular membrane. Not only can you identify the membrane, but as you can see here, you can identify the extent and the direction of growth of the membrane. And here's a patient who had choroidal membrane, and after anti-VEGF treatment, you can see the regression. But equally important, the same patient, you can see the regression which is here, and now in the same patient, there is no edema here, but you can see that there is a fresh outgrowth of the neovascular network. And this is very important because in a way it's like pre-perimetric glaucoma. You can actually identify early vascular growth even before fluid occurs. And I would give importance to this because, as I mentioned to you, the importance of the resolution of the scan. And you can see here, this is a 9 out of 10 and 9 out of 10. That means the scan quality is very, very high, and therefore you can give it great weightage in specifying that, yes, there is worsening of the disease. On the other hand, sometimes you have a situation like this where you have cystoid spaces, not outer retinal tubulations, but you want to know, is this an endpoint for this patient? And here you can see what is known as a prune tree appearance, where the neovascularization has regressed, and therefore you can say that this is an endpoint even though there are cystoid spaces and no outer retinal tubulations which would ordinarily be used to stop treatment. Then, of course, there are situations where you have images like this on conventional OCT, which is like almost like a drusenoid PED. And if you were to see these two pictures, they would appear similar. They're two different patients, but in this case, because of OCT angiography, you can identify an incipient choroidal neovascular membrane. Now, whether you treat or not is different, but it will definitely change your follow-up advice to this patient. So this is an extremely important point of practical importance in these type of patients. Then, of course, there are other types of choroidal neovascular membranes, and here, of course, you have a FFA of IPCV. This is a ICG angiogram, but again, in OCT angiography, you are able to identify the BVN. You may not see the polyps, but the BVNs are definitely and this can be used to follow up patients. This is another patient where you can see severe cystoid spaces in the retina, but one would like to identify what type of choroidal neovascular membrane is this, or AMD is this. And you can see with OCT angiography a clear flow signal in a vertical direction, as well as in the 3D imaging by going layer by layer, you can identify this as a RAP lesion, which will again change the prognosis and your line of treatment. So this is again of practical importance when you're managing patients with CNVM. Now here's another patient where you see hyperreflective dots, intraretinal cystoid spaces, PED, and you see this vertical, strong hyperreflective signal. So is this a RAP lesion? It could be, but by doing an OCT angiography, again, segmentation is very important, as I explained to you earlier. Now here you can see the segmentation has not been done correctly. So what you're seeing is the edge of the PED, and this is an artifact. This is not the SR-NVM, but on the other hand, if you segment properly, you can actually identify that this is a type 1 lesion and not a RAP lesion. And this can be, the presence of the CNVM can be correlated by the flow signal, which is the red dot which you're seeing in the same location as the CNVM. So this is again important because you're able to identify precisely what type of AMD this is. Again, OCT angiography absolutely shines in non-AMD choroidal neovascularization. Just two examples. This is a patient with CR, and this is an ICG angiogram. Very difficult because they have a lot of RP disease, RP leakage. You're not able to identify a CNVM. But by doing OCT angiography, it's again very easy to identify these lesions. The other situation where OCT angiography is very useful is patients with uveitis who may develop choroidal neovascular membrane. Now here again, this is a patient with chronic uveitis, multiple lesions, and this is an ICG angiogram, and you're not able to clearly or precisely identify is there a CNVM or not. But if you do an OCT angiography, the CNVM is extremely well defined. Of course, artifacts are present, but in which form of imaging is there no artifacts? Practically every form of imaging, whether it is conventional photography or with wide-angle photography, artifacts are present. Just a few points. The most common artifact is projection artifact, where you have an overlay of the superficial vessels, but the software allows you to remove the artifacts, and very often just by clicking that, you can remove the artifact and identify the vessel flow in precisely the area that you are segmenting. Then yes, displacement and doubling can cause confusion, but this is an example of a patient with very advanced disease, and this her vision was 6 by 120 and it had reduced to 1 by 60. So even with a vision of 1 by 60, with the imaging technology, with some experience and with some vocal encouragement, you can get excellent imaging. So there are some handicaps, there are some shortcomings, but by improving your technique and by using some external or internal fixation, you can still get good imaging even with poor vision. Hypertransmission can cause artifacts. For example, this may appear to be a CNVM, but if you see that this is an area of retinal thinning and therefore there is hypertransmission, and you can see that it does not correlate precisely with the area of edema. Probably the single most useful method to improve your images as a practical point in any form of OCT is to ensure that you put some form of tear film supplements before you do any form of OCT. And you can see here, this is the right eye of this patient, a very good image. The left eye of this patient had multiple complications, multiple surgeries, and you can see these little reflections which are caused by poor tear film, but by applying a tear film supplement, the quality of the image greatly improves. So the advantages of OCT angiography is that it's fast, it's three-dimensional, it gives you quantitative measurements, there is no need for any injection, patients' acceptance for doing the test and for repeating the test is very high. Then of course you get a layer-by-layer analysis. You can combine it with unfast imaging. There is no limitation of a transit window in the sense if you miss the time, suppose you're doing a conventional angiography and the patient starts vomiting, then you will lost the transit window. And of course, there's no obscuration of the image because of dye leakage, as you saw on the patient with diabetic retinopathy. The disadvantage, of course, is that leakage is not seen. Then it's difficult to identify microaneurysms and polyps, but you can use BVNs and other methods to identify the presence of disease. Artifacts can occur. Loss of image quality can occur if there is a cataract, poor tear film, or vitreous hemorrhage. There is a limited field of view, but that's improving. And there is need for post-processing. So unless you do proper post-processing and segmentation, you will not be able to make a correct diagnosis. Of course, there's a higher capital expense, and there are very few clinical trials on OCT angiography as yet. So we need to get more information from the research side using OCT angiography so that we can apply that information better. Thank you for your attention.
Atul, this one. I would
Thank you.
like to ask a question from Atul and opinion from Anirudh also. When you, first of all, if you are using the forum software, you are able to, on your table, do the correct segmentation, which your technician might not have done. So that's one advantage I see. Second, do you feel by Octa, we are over-diagnosing some cases of classic CNVM type 1 and labeling them very early in the disease as mistaking them for a branching vascular network and putting them as PCV? Do you feel that this phenomenon is there? This is my one question. And my second question is that if you have a dry lesion and you're following up the patient and the patient suddenly deteriorates and you do an Octa, you many times see a membrane sitting underneath. Would you treat this patient immediately or follow him up on Octa? These are my two questions.
Yeah, so to answer the first question, basically, I think the controversy or the debate regarding type 1 neovascularization and BVN is because of the article by Richard Spade, where they mentioned that this is a type of type 1 neovascularization which later on develops polyps. So in either case, the diagnosis is neovascularization. One subsequently goes in the conventional type 1 way, and the other goes to subsequently develop polypoidal lesions.
In any case, we'll be treating them the
Yes.
same way.
Yeah.
But one has more hemorrhagic phenomena. If it develops polyp, one may not develop polyps and not have a hemorrhagic phenomena. So that is the basic. And in Indian patients, it's significant because nearly 55% of the patients we are seeing wet AMD are actually PCV.
Yeah, and to the second question was related to the
Follow-up of
Yeah,
a
so
dry
again, yeah,
lesion.
so-
Patient is going on at 612 with a dry lesion and suddenly it becomes 624 or 636. And you do an Octa and you see a membrane sitting there.
Yeah, so if you have to identify the reason for deterioration in vision. If there's fluid, you would treat. If there's no fluid, then you probably advise a very close follow-up.
I think in
That's
the
just
PNV,
the answer I wanted. Thank you.
I think that the PNV is a very common condition where we see the membrane in Octa, but in conventional OCT there is no fluid. So I think these are the cases where we need to observe rather than jump into treatment.
Yeah, rather than jump into that. I thought it's a very important message to pass, not to inject, but to watch for a couple of months, monitor the clinical picture and the OCT and the Octa picture.
So still, do you do angiogram and Octa together in all of the cases, or there are certain indications where you are doing only Octa?
Since I've also used a spectralis, I do multimodal, but increasingly so I'm doing less and less fluorescein. Because again, as the technology improves, as your ability to do the scan and interpretation improves, as the wide angle Octa
But
comes in.
cases like CSR still needs an DFA to be done.
Yes, especially those who are confounding, who come repeatedly, then one would do a combined.
In
Not
fact,
just use Octa.
in fact, I see in my clinical practice as a supplemental angiography, ICG has gone up more, and fluorescein cases in AMD have come down. ICG has improved because I want to see if there are polyps. especially if I see a hemorrhage somewhere or a PED somewhere which I could be extrafoveal and I could just laser it off after a couple of injections.
So we are used to this OCT biomarkers. So I think there are some Oct biomarkers also which will eventually guide the treatment management. So anything you want to say about the Oct biomarkers?
No, as I said, the biomarkers would be particularly useful when they are used in clinical trials, because that would, strengthen their importance. So till then, what I would say is that only use those biomarkers where you have got a good high resolution scan, because sometimes you're likely to have mistakes or some artifacts if your scan is not of a good quality. So as I showed you, the neovascularization after regression showed early growth, but I used that as an important biomarker only because the scan quality was very, very high. If the scan quality was, say, 4 or 5 out of 10, then I would probably not give it as much importance.
Thank you very much for the interesting session. And if there are no questions, we'll close the session. Thank you.